or 6 weeks ago with Dr. Carr, and he suggested that I pull the medical staff together and talk about health reform and the impact of health reform on physicians. And it so happened that the next day or so, I was meeting with a firm on an unrelated matter and got to talking about this, and they said they had someone right in the house that's an expert on this. So I met Steve. Steve, as I understand it, was the chief operating officer for the Ohio Department of Health for a couple of years under the Strickland. Casey, under the Casey administration. So we're really pleased that Steve had the time to come out here. Steve is had lived in Galway, very familiar with us. With that, I'll turn it over.
Thanks. Well, good morning, everybody. We're going to spend a little bit of time today talking a little bit about the Affordable Care Act. Kind of like a 2-year, it's been 2 years since it's been signed by the President. What's been going on those 2 years, what we can expect going into 14. 14 is a real big year for the Affordable Care Act. But then also talking about some of the healthcare reform initiatives that are going on. And then lastly, talking about some of the things that are going on in the Ohio budget and how that all kind of relates to you and relates to the whole healthcare industry going forward. So the Affordable Care Act was signed into law March 2010. Made some sweeping changes in healthcare, really kind of since post-World War II. One of the biggest attributes of the Affordable Care Act is it requires everybody to have insurance. That goes into effect on January 1st, 14. But it also makes some changes on the insurer side of the equation. Insurers will be prevented from denying coverage to people with pre-existing conditions. Individuals without employer-sponsored health insurance have access to new plans. We'll talk a little bit about the exchanges and premium assistance and how that affects them. Tax credits and to subsidize premiums. And small businesses will receive some assistance for offering insurance. Early on, after the Affordable Care Act was passed, the CBO, the Congressional Budget Office, kind of did this. I think it's kind of interesting to kind of stay focused on, especially as providers. Because what you see here is that before the law, there were 54 million Americans that are uninsured. And then they're estimating that by 2019, when the Affordable Care Act is kind of like fully in effect, they're still going to see 23 million people uninsured. So if you ask the question, you say, wait a minute, there's an insurance mandate, there's insurance exchanges, there's places for people to go to buy insurance, so why do we still end up with 23 million people uninsured? By that time, those will be people that will be uninsured by choice. They will say, it's easier for me to pay the penalty, I won't go into the exchange. For an individual in 2014 that doesn't want to get insurance, they will be charged $95. By 2019, that will go up to $795. Now, the question behind that from a policy perspective is, how are you going to collect on that? How's the federal government going to collect on that? The theory is, and I say this kind of jokingly with all the stuff going on in India right now, is that the IRS will collect that. They got some of their own problems going on right now about credibility and everything. So, but in theory, that's what they'll just really kind of take it right off of your taxes when you're filling out your 1040 and those types of things. So, but important to understand that even at full implementation, we'll still have folks coming into your facilities that will be on uncompensated care without insurance. And we need to recognize that as we're looking at some of the payment reform initiatives as well. So the premium impacts by different groups. The non-group market, or what we call the individual market, you'll see a 10 to 13% increase in premiums after the law is into full effect. And while that might seem like a big jump, really right now in Ohio, what we see is that in some of that individual market, you can see anywhere from 20 to 40% increases. So it helps to stabilize that market a little bit. In the small group market, which is the 0 to 100 employees, Same thing, right now in Ohio, we're still seeing small employers getting 20, 30, 40% increases in their premiums on an annualized basis. So to stabilize these markets becomes somewhat important as far as the affordability. So let me take a step back for a second. You know, some folks are saying, why are we doing all this? You know, why the Affordable Care Act? And, you know, so there's an issue there about people that are uninsured, making sure they get insurance. But quite frankly, and some of the things that we'll talk about in a little bit, one of the things we're seeing is that the healthcare industry as a whole in this country it's unsustainable. I mean, we pay a lot of money and get very little for it. So compared to other countries, the United States ranks 37th in health outcomes as compared to other countries. And yet we spend more than 17 other countries on healthcare. So we spend a lot and we get very little for it. So that unsustainability has kind of led to some of these reform initiatives. What I'll also point out to you as we go further is some of the reforms we're seeing right now are actually being driven by the healthcare industry itself. In other words, healthcare providers recognizing that we got to do things differently, and also insurers saying we have to do things differently. And so some of the things are happening right now in the marketplace, not because of the Affordable Care Act, not because there's a provision in the Affordable Care Act, but because the market's driving us that way. And so we'll talk a little bit about some of those issues. So not long after the Affordable Care Act was passed, 21 states, including Ohio, filed a suit against the federal government saying that the Affordable Care Act was unconstitutional. You can't make people get health insurance, that it was outside of the purview of Congress to do this. So in June of 2012, the U.S. Supreme Court came out and said that requiring people to have insurance is constitutional because they determined that that was a tax. I don't know how you get there, but they said it's a tax. So it's a tax, and so therefore it's within Congress's authority to implement a tax on individuals across state lines, across the country. More importantly, what it did is it also ruled that the federal government cannot mandate the states to do Medicaid expansion, and that states have the ability to opt out, and if they do opt out, they can't be punished by removing all of their Medicaid funding. So that's led to the debate that we're in right now in the budget bill with whether or not Ohio is going to expand Medicaid up to 138% of poverty, and we'll talk a lot about that later on. So that was a pretty important ruling, and it kind of said we're moving forward. So changes that affect the ACA come 2014. We talked about the individuals that have to have insurance. There will be the expansion of Medicaid by choice by the different states. Presumptive eligibility for Medicaid, the exchanges go into effect. Now, the health insurance exchanges, every state will have an exchange. Whether or not the state runs their own exchange or they have the federal government run it is going to be up to them. Here in Ohio, we're like 21, 22 other states where we've decided to do what's called the partnership model or the hybrid model. So the federal government will actually come in and set up the exchange and fund the exchange. Ohio will still remain regulatory control over the insurance products going into the exchange. So the Ohio Department of Insurance right now is reviewing those products. As a matter of fact, Mary Taylor came out yesterday, the Lieutenant Governor, who's also the Director of the Department of Insurance, and said there were 14 plans, 14 insurers that are putting products into the exchange, and they've looked at those products. So they're going through and making sure that they meet all of the basic benefit design requirements under the ACA, those types of things. So the exchanges go into effect in 14. So what that means is if I am an individual and I don't have access to health insurance either through my employer, through the government, through something else, I can go to the exchange. I can buy an insurance product in the exchange. Depending on my family size and income, I might be able to get what's called a premium subsidy to help me pay for that. So if my premium copay is $500 a month and I'm in a family of 4 and I'm making $30,000 a year, I might be eligible for some premium assistance, which will help. Instead of me paying that whole $500, I might pay $100 of it and I'll get $400 in either a tax credit or actual premium assistance out of the exchange. And the reason why I explain that is because it's important to understand that for the insurers going forward, any product they put into the exchange, any health insurance product they put in the exchange that meets the benefit design of the exchange, by law they have to offer that same product out in the open market. So when you read about whether or not insurers, I mean, I'm sure you've seen some of the stuff in the media about insurers saying, well, we don't know if we're going to put products in the exchange, we don't know if we're going to play or not. That's one of the reasons why, is because the benefit design is pretty rich inside the exchange, so it makes the product very expensive. So, but inside the exchange, you have premium assistance. Out in the commercial market, you don't. So if I have to offer that same product out in the commercial market, it makes it very difficult to have people staying outside the exchange. So there's some concerns on the insurers about how that works. And I'm going to talk about some policy considerations that states could consider going forward. So we talked about the premium, insurance premiums and cost sharing subsidies. No annual limits on coverage, so you don't get to the point where right now in Ohio we have about 3,500 people in a high-risk pool. Does everybody understand the concepts of a high-risk pool? These are people who have been forced out of their health insurance. Either they've reached their lifetime maximum, might be a cancer patient, somebody like that that doesn't have access. They've reached that $1 million cap and now they're uninsurable. So a high-risk pool is some place where somebody can go to get health insurance and they're kind of outside of the employer, so the state actually has a high-risk pool. Those people will actually go into the exchange in 2014 and purchase their health insurance there, but there won't be any limits on their annual coverage. So you can start to see why when you read in the paper about the fear about what they call rate shock. If you've seen that, when they're talking about 23% increases in premiums just right out of the gate, or 30% increases in premiums, that rate shock is driven by the fact that no pre-existing conditions, no limits on annual coverage or on the annual limits and everything. And just from an actuarial standpoint, you can see where insurers are getting nervous about how they price that product out to make sure that they don't end up on the downside of that. The definition of essential health benefits, that came out early this spring. And then kind of one of the exciting things that I've been spending some time on is the wellness programs. Employers will be given opportunities to give a 20 or 30% premium deduction for employees that exhibit certain behaviors on a wellness program. On the 20% side, it's pretty much what we've seen right now. I fill out my health risk appraisal, I go get my annual physical, those types of activities. On the 30% side, it's basically saying my cholesterol is in right limits, my blood glucose is in control, my weight's in control, and so those biometric screenings that you can actually show that you are keeping yourself healthy to the point where you don't end up in secondary, tertiary care, then that individual can be eligible for a 30% decrease on their premiums from their employer. So the other thing is fees on the health insurance sector increase. One of the ways, and I'll show you how the ACA is paid for, across the country, insurers are going to pay $60 billion more in taxes starting in 2014. And so then we talk about the pre-existing conditions. Businesses with 50 or more employees must provide health insurance coverage or pay a penalty. This is one of the big aspects of 14. So you have the insurance mandate for individuals, but then employers have to offer health insurance or they get penalized. And we'll talk a little bit about the penalties and how that kind of works. So and then Medicare payments for hospital-acquired infections. I think you're all dealing with the fact right now that there's going to be some reductions in some of your Medicare reimbursements based off of readmissions due to infections, those types of things. So that's already starting to, actually some of that's already starting to kick in. So implications for employers. And one of the things as I do this presentation for healthcare providers, I have to remind them that you're an employer too. So some of these things apply to you depending on your practice and if you're in private practice or if you're a staff member of the hospital. So for businesses with 50 or more employees, you have to provide the health insurance and pay the penalty. What's interesting is the Joint Committee on Tax came out with an estimate that says that employers will pay $52 billion in penalties for non-compliance. So non-compliance meaning I'm not going to provide my employees with health insurance, so I'm going to pay the $2,000 penalty and push them into the exchange. When I do this presentation for chambers of commerce or employer groups, I've had some employers that have said, look, I'm out of the game, 2014 comes around, I'm not going to provide health insurance because it's cheaper for me to put people into the exchange at $2,000 and pay a $2,000 penalty than to pay $14,000, which is the average cost of a PPO product. Okay, so $2,000 to $14,000. Well, then I come back and I'm going, really? And they go, yeah. I'm like, really? And they're like, well, what do you mean? I said, well, right now, today, you get a dollar for dollar tax deduction for every dollar you spend on insurance premiums for your employees. So if you're spending $500,000 on insurance, on health insurance, that is an above the line tax deduction for you. If you push your employees into the exchange and pay the $2,000 penalty, not only are you paying the penalty, you lose the $500,000 tax deduction. So now all of a sudden, $14,000 to $2,000 might be $14,000 to $10,000 or $14,000 to $8,000. And so you have to make some of those decisions. There's a lot of factors involved in just saying, I'm going to pay the penalty. I looked at a national study that was done by the Federation of Employee Benefits last summer. 86% of employers across the country said they will continue to offer health insurance benefits even after the exchanges go into effect. Why? 40% said because of recruitment and retention, the best and the brightest. You know, even in Central Ohio, in Columbus, where I'm at right now, our unemployment rate in Central Ohio is below even the state rate. You know, right now the state's at about 7% unemployment. In Central Ohio, we're flirting around the 4.5%, 5% unemployment. So you're at the point right now where employers in Central Ohio are really competing for the best and the brightest. Why do people make decisions where they go to work? Salary, benefits. So for some employers, it is a recruitment and retention. Another 40% said just employee satisfaction. 10% said union contracts. I have labor contracts. In my labor contract says I have to offer health insurance, so I'm going to continue doing that. So those are some of the things that are the implications for some of the employers. The fourth bullet down there I thought is kind of interesting, a provision I read in the bill when it first came out. So it provides a 50% tax credit to small employers who purchase health insurance under these conditions. You have no more than 25 employees and nobody in the shop makes more than $50,000 a year. So, I mean, think about that for a second and you go like, okay, where are you going to find a company where somebody in that company, where the president, CEO, isn't making more than $50,000 a year? So while it sounds good, it looks good on paper as far as implementation, I don't know if it's going to really occur. So now here's the real interesting thing. So you got some employers that are coming out saying, well, if I have to pay, if I'm on the hook for offering health insurance, if I have more than 50 full-time employees, I'll just put everybody on part-time. I'll get around with that. Not really, because there is actually a formula that considers that it's called the calculation of full-time equivalents. And I got this out of the U.S. Chamber of Commerce just to give you an idea of how this plays out. So you have 48 full-time employees working more than 40 hours a week, or actually under the ACA over 30 hours a week. And you have 3 part-time employees who work 20 hours a week, 3 part-time employees who work 10 hours a week. So in 2014, the 3 part-time employees working 20 hours a week work an aggregate of 240 hours a month. The 10 hours work an aggregate of 120 hours a month. So you combine those two, it's 360 hours a month aggregate. You divide that by 120. Where they come up with 120, I don't know, but 120. And so you come up with 3 full-time equivalents, not 3 full-time employees, 3 full-time equivalents. 3 plus 48 is 51. That employer's on the hook. So for an employer that says, I got 60 full-time employees, I'll go down to 40 full-time employees and then hire another 30 part-time employees. By the time you do those calculations, you might be right back over the 50. And so that determines. Now, the interesting thing is that all that does is it says that the employer has to offer health insurance to the full-time employees. So you don't have to offer them to the part-time employees, you just have to offer it to the full-time. You just have to make the offer there. And that's what becomes interesting. I put this flow chart together. I found quite a few flow charts about how the ACA works. This is the easiest one to migrate through. There was a couple that looked like something from my biochemistry when I was in undergrad, and I decided not to put those in here. So really what it does, it just walks you through and it says if you have 50 or more full-time employees, including full-time equivalents, the employer offers coverage. Nobody goes out and gets a tax credit or goes into the exchange, and the employee accepts the plan, there's no employer penalty. If somebody, the employer goes out and gets a tax credit, goes into the exchange and asks for a tax credit, they can get an annual penalty of $3,000 a month. And that's because of the coverage is unaffordable. So somebody would say, okay, well, how do you determine whether or not coverage is unaffordable for an employee? If an employee pays 9.5% of the premium copay, 9.5% of their annual salary toward the premium copay, then it's considered unaffordable. So if I'm paying $250, and I kind of calculated this out, if you're making $30,000 a year, you would have to pay almost like $1,500 a month in a premium copay. So that's, we normally don't see that kind of, those types of numbers, but it gives you an idea of what that would relate to. So factors for employers to consider about the exchanges, so the elimination of expenditures for purchasing health insurance. Once again, I'm out of the business. I don't have to go out and shop that. It's the second largest line item in my budget. I don't have to do it anymore. I'll just pay the penalty. And like I said, paying the penalty might seem more attractive than offering insurance. The reduction of job lock by employees through portability of an exchange. If an employee goes into the exchange and buys a product, it makes no difference where they work. That is still their health insurance product. So once again, getting back to the retention issue, that becomes a benefit for the employer to continue offering health insurance because it's too easy for employees to start jumping jobs if they're not locked into benefits by the employer. Like we talked about the loss of the tax exemption for offering health insurance, the corporate tax implications. We talked about the recruitment, retention, the labor incentives. The penalties are non-deductible either. So if I'm paying the $2,000 penalty as an employer, I don't get to take that off my taxes either. So there are tax implications to the employer. So let's talk about providers, what you guys do. So what are some of the implications of the ACA for providers? Well, just sorry.
Quick on the insurance. Does it mandate that you have to cover the families of your employees
Yep.
as well? Just the employees?
Just the employee.
So the cost of that monthly policy, though, may be over that 9.5% if they choose to cover their family under their employer's plan.
Could be.
But you're
That doesn't
okay.
apply. You're not. That doesn't apply to the employer. And that was one of the things I had to do a lot of research on because there was a couple of articles that talked about the household income at 9.5% of unaffordability. But actually, it came back and after I did some more digging, the only way that the employer can be held is based off of the salary and wages that they pay. So it's 9.5 of that because it's hard to track on the other part of it. Yes, sir.
So this is a way of not only controlling, insurability, but also how much you pay an employee. Because you could offer an insurance plan and still get penalized for not, providing the insurance if you're not paying the employee enough to reach that 9.5% threshold.
Yeah, you can have those kind of conditions occur. But now, once again, if you kind of play with the numbers and you look at what that 9.5% means, it's very elevated to what you would see a normal employee pay in a premium copay right now. I mean, it's pretty high. I mean, like I said, so you figure what's 10% of somebody making $30,000 a year would be $3,000 a year. So $3,000 a year is what, probably 300, somewhere a little less than $300, $280 a month, something like that. So in some cases, you know, that could be depending on the employer and what they're doing. You know, but normally with a good product, we don't see that happening, but it could happen. So implications for providers, mandates on safety, quality, and cost. So what we're starting to see is, you know, looking at the way we talk about it here in Ohio is the movement of, instead of paying for volume, is paying for value. So what we're trying to do is, or what they're trying to do is get to the point where we're looking at outcomes. What outcomes do we want to achieve, and how do you want to pay for them, and what are those issues. On the safety side, it's kind of like, you know, some of the things that you're already implementing, you know, elimination of wrong site surgeries, you know, those types of issues that have popped up over the years, and making sure not, and Medicare won't pay for some of that stuff. Encourages the formation of social networks and collaboratives. When I do this presentation in front of healthcare providers, one of the things I tell them is, over the next few years, you'll develop partnerships with people you never thought you would develop partnerships with in the past. Because as we start moving from a system where it's more provider-centered to more of a patient-centered, and we'll talk about the patient-centered medical home model in a little bit, but as you start working around the patient, one of the things that providers will have to do is saying, what are all those supports that I need wrapped around that patient to make sure that we're achieving good health outcomes? So, for instance, working with the faith-based community in your communities, working with other social providers in the community in a more collaborative effort. And when I say more collaborative effort, not just let's sit around the table and talk about this, but, you know, through your electronic medical records, making sure that people that, you know, as long as it falls within the HIPAA requirements, making sure that some of your social collaboratives and everything actually have access to, you know, your electronic medical records. So that way, if one of your patients ends up in their facility and they need some kind of follow-up care, something gets identified, they can actually be transferring that information right in through the EMR directly to you. And so that's the other thing, is increased supports and transparency and increases in IT capacity. So we're seeing, you know, everybody moving toward the electronic medical record, the health information exchanges. You know, here in Ohio, we have CliniSync, which will be the health information exchange platform for most of Ohio, Southwest Ohio, Hamilton County, and those counties down there actually started years ago with HealthBridge. I don't know if you've ever heard of HealthBridge, but it's down in Southwest Ohio. So we'll have two different platforms here in Ohio. And what that means is, does it make any difference if you're on Epic or Genesis or whatever EMR you're on as a provider? As you put your health information into the exchange, into the health information exchange, it's on a platform which will allow all that information to transfer back and forth regardless of what the electronic medical record platform is. So what that means for patients is, if you've got a patient here, you know, in London, Ohio, that might need to go up to, you know, Columbus or the Cleveland Clinic for tertiary care, you know, by the time they get up there, their information's already there. Or as you're in consultation maybe with a provider in another community, you can actually direct them through the exchange to that information they can get. And that's what's going to be important. One of the things that you'll see when we talk about safety, quality, and cost is, so, you know, like, well, personal experience. I mean, I don't care about it. I mean, no worries about HIPAA here, okay? So, a year ago, I had L4, L5, S1 fusion. That's spinal fusion. So obviously I'm working with a orthopedic surgeon, working with my primary care doc, and this, that, and the other. So I'm going to see a variety of different providers, but when I go see one provider and they take an x-ray of my back or an MRI or whatever, or get lab work done, when I go to see my surgeon, usually by the time I got to his office, all that information was already loaded up. So I didn't have to have another MRI done. I didn't have to have more lab work done. Everything was pulled up right into the file. And then there was that level of transfer of information. Actually, my surgeon after a while said, you know, I should have never taking on a healthcare consultant as a client, because I was constantly asking him questions about how this, is it working, isn't it working, are you getting all this information? I had a lot of questions for him, and that kind of stuff. So that's kind of some of the stuff. Now, the supports and experimentation with new payment and delivery models. Ohio's been granted a couple grants that we'll talk about later. The Ohio Department of Health, when I was working with Dr. Winslow, we'll talk about those, but actually there are 4 payment reform initiatives that are actually going on here in Ohio right now, and looking at how we coordinate care better, how we pay for outcomes versus paying for volume. So some of those initiatives are going on right now here in Ohio. So from the ACA, so you're looking at this implementation of this health policy reform for the entire country, and folks go, geez, is this really going to work or isn't it going to work? What do we learn? Well, if you remember back in 2006 when Mitt Romney was the governor of Massachusetts, they passed the Massachusetts plan. And if you look at it, the Massachusetts plan is almost a case study of the Affordable Care Act. Why? They actually did an insurance mandate. They did a health insurance exchange where people could go buy health insurance. They increased their Medicaid up to 300% of poverty in Massachusetts. That means a family of 4 making $66,000 a year would be eligible for Medicaid in Massachusetts. What was interesting is that prior to the law, their uninsured hovered around 10%. In Ohio, we're at 11%. So in 2008, 2 years after the law went into effect, the rate fell between 2.6 and 4.1%, depending on which report you're looking at. So did they decrease their uninsured population? Absolutely. What I think is important to look at is, look at the second to the last bullet. The state still struggles with overall healthcare costs, which are 15% higher than the national average. You say, wait a minute, okay. We insured more people, we got them into exchanges and that kind of stuff. We reduced, and invariably reduced uncompensated care. So why are healthcare costs higher? Well, and I think what they do is, the one thing they forgot to look at is, well, 2 things they forgot to look at that we need to pay attention to. One is utilization. Where are people going to get care? And this is my euphemism, just because you give somebody a card and $20 doesn't mean they're going to be good healthcare consumers. If somebody that's been uninsured for a number of years becomes insured, they just end up in your ED, instead of uncompensated care, they've got, a card and $20. And is that where we want to see people getting care, episodic care versus, care coordination and that type of thing? So, and that's the one thing that they didn't really pay much attention to. The other thing that really affected Massachusetts is there was such a lack of primary care providers that people were waiting anywhere from 12 to 18 months just to get in to see a primary care provider. And so the lack of providers. So once again, you insure everybody, but if you don't have the system, the infrastructure to provide that care, where are people going to go for care then? You go right back to the ED. So that's one of the things we've learned, and we're trying to avoid as we move forward. So paying for the Affordable Care Act. In January this year, everybody's Medicare premium, your payroll tax went up. So we're paying for that in our Medicare tax. There's an annual fee on health insurance that generates $60 billion. What they call the 40% excise tax on health insurance premiums, that's called the Cadillac plans. So if an employer provides a health insurance plan at over $27,400 for a family, they'll be charged a 40% excise tax on that. Some of the unions are very nervous about this because, as you probably can imagine, with the unions, they actually negotiate better health benefits versus salaries when it comes to negotiation. So you see some pretty hefty plans, benefit plans on that side. And so you see that the annual fee on manufacturers of drugs, importers of branded drugs, $27 billion. Medical devices, Invacare that's up in Cleveland, You know, they'll be paying a 2.3% excise tax on the products that they produce. They're a multi-billion-dollar company here in Ohio, so they will pay more taxes. So you see there's a whole slew of taxes here that help pay for the ACA. Then on the other side is reduced funding for the Medicare Advantage plans, reduced Medicare home health care payments, and reduced certain Medicare hospital payments. So overall, if you look at it from this perspective, the ACA in full implementation is about $972 billion, just a little bit under $1 trillion. About half of that comes from the taxes that I just talked about, and the other half comes from cuts to Medicare. So that's how it gets paid for. What's important to understand about that is that we get into the debate about Medicaid expansion here in Ohio. Some legislators will say, well, we don't want to support Medicaid expansion because it's going to add to the federal deficit. And we have to educate them. I mean, part of my job is we educate them and say, no, that's not going to add to the federal deficit because we're already paying for it. This is coming out of the funds of the ACA, so you've got insurers in Ohio that are paying for it. You've got employers in Ohio that are already paying for it. That's our tax dollars that we're bringing back into Ohio to provide care to access to insurance to people that haven't had insurance in the past. So what are we doing here in Ohio? Governor Kasich and the Ohio Department of Health, we've been working, or I have to keep saying we, I'm not there anymore. They've been working on some transformational activities and some budget priorities. Expanding workforce capabilities. So one of the things we're trying to do is increase the number of working with the medical schools and nursing schools in Ohio, is encouraging more people to get into medical programs, especially on the primary care side. And so you're looking at some of that. Some of the curriculum design is being changed so that we're actually producing young physicians and nurses that know how to work in a patient-centered medical home model and that care-coordinated type of model of care. Paying for health care based off of value instead of volume. Coordinating programs for children. Modernizing Medicaid, streamlining health and human services. On the coordinating programs for children, that was something that was kind of near and dear to my heart when I was at ODH, because you see many different programs, WIC, Bureau of Children with Medical Handicaps, CFHS, you see all these different programs, and what happens is over the years, we have, through categorical funding, what happens is we say, well, you're a WIC patient, or you're a BCMH patient, or those types of, or you're an early intervention, a special needs kid. Well, we got to kind of challenge ourselves to walk away from that and saying, no, you're Bobby Smith, and you might have a primary diagnosis and several secondary diagnoses, and we need to figure out how we're going to coordinate your care so that we can produce good health outcomes and reduce our spending and also reduce duplication as we're doing that. So that's one of the things that we're working on, that the state's working on. Why focus on the primary healthcare workforce in Ohio? There is a maldistribution, and we look at our HPSAs, the health professional shortage areas. 1.1 million Ohioans are underserved for primary care. There's 11 million people in Ohio, so basically about 10% of people in Ohio are underserved for primary care. We would need an additional 118 primary care physicians, or 282 to reach the 2,000 to 1 ratio. Nearly 1.4 million Ohioans are underserved for dental care. Actually, dental health is the #1 unmet public health need in Ohio. Has been when I was in public health as a health commissioner, and it still is today. There's a huge need for dentists and dental providers. And then on the mental health side, nearly 2.7 million. Mike?
Yeah, the other thing, you might hit this, that is misleading. I had done some research looking at Ohio by county, and the ratio of primary care to population in Franklin, for example, I believe is in the 900 to 1 range,
right.
Where when you get out into the rural areas, that number is much bigger. So,
absolutely.
So there's also not just a shortage, but there's a distribution problem.
Absolutely. without a doubt. And I'm going to come right back to that, because one of the things that we're kind of seeing something happening in the healthcare delivery system here in Ohio that is going to be interesting. So 2.7 million Ohioans underserved for mental health care. I do some work with a freestanding psych hospital in Columbus, looking at some of their data. In a 3-month period, 200 Medicaid beneficiaries went to one of the hospitals, went to one of the EDs in Central Ohio for mental health services and were denied. I mean, just they actually sat there. I mean, their average wait in the ED, 3 days. Some of them just walked out. So what happens is you see people with a primary diagnosis of mental health, especially Medicaid beneficiaries, because they track on them, will have 12 to 18 ED visits a year. So once again, when we talk about paying for outcomes and paying for value, is somehow we got to get better at making sure when those folks come into the ED, we get them plugged into the appropriate mental health services and making sure that they don't end up back in the ED 18 times a year, but they're supported through the community mental health system, that they're in the appropriate level of care. And obviously one of the things that we do see is that if some of their mental health care isn't appropriately taken care of, as it becomes worse, then they either become violent offenders or something really bad starts to happen. I always hesitate to bring this up, but when you look at the Newtown, Connecticut issue, the Virginia Tech issue, the issue down in Texas, over in Colorado, what were the two most significant factors? Automatic weapons and mental health. Those individuals had a mental health disease and they had access to an automatic weapon. So that kind of tells some of the stories. So here's one of the grants that we got and to do some of the payment reform. We were only one of 2 states to get $3 million, Ohio and Idaho. So it was actually to design a model for service delivery and payment reform in the state, and then also to reward recipients to apply for the support to the test model they designed. So basically what's happening here in Ohio, what they're doing with the CMMI grant here, the SIM grant, what they call it and everything, is encouraging providers on that care coordination piece, looking at that patient-centered medical home model, and then doing enhanced reimbursement for it. Because we know that right now, if you as a provider, to cover your cost, to make a decent living and everything, I might have to see 25, 30, 40 patients a day in my office. But yet, you don't get that time to really spend with them to do the things that you were trained to do, the doctoring type of stuff, because you're working them through the system, right? The SIM grant actually is trying to develop a payment reform system that says, we don't want you to see 40 patients a day. We want you to see as many patients as you need to see to get good outcomes, that you're spending time with them and reaching toward great health outcomes for them, and it's stuff that you can track on. And so it's building those types of systems to make sure. We had Dr. Paul Grundy in from IBM 3 times when I was at ODH into Ohio. Dr. Grundy works for IBM. He is their director of their patient-centered medical home model of care for IBM as an industry. So you figure IBM, big company all over the country. They will only set up shop in communities where they have patient-centered medical home available for their employees, because they've seen the value, the return on investment for doing that, for doing enhanced payment reform, for reaching some of those outcomes, PCMH. What I thought was funny was the first time Dr. Wimslow and I went up to the airport, picked up Dr. Grundy, we're driving him back down through Columbus, and we get halfway down and he looks at us and he says, you know what, I'd never set up shop here in Columbus, Ohio for IBM. We're kind of like, why? And he said, I just passed 2 billboards that said, we're the #1 cardiology hospital in Central Ohio from 2 different hospitals. He said, I don't want to pay for that. As an employer, I don't want to pay for top cardiology services. I want to pay for good health outcomes. I want to pay for keeping my employees out of the hospital. I'm willing to pay good money for that, but I want to make sure that we're producing good health outcomes. And so that's that. Mike, go ahead.
So a question I have here, so on the previous slide, we got a shortage in primary care docs.
Right.
So we moved to this slide here,
Mhm.
and we say, okay, just for example, we're going to set up a program that allows the physician to go from, let's say, 35 patients a day down to 24.
Yeah.
Okay, so until the outcomes start to play through,
Right.
how do you handle the bubble that you're going to have in terms of access?
Great question. So when we talk to Dr. Grundy and when we talk about the patient-centered medical home model of care, he said the two main important parts of PCMH is, number one is electronic connectivity. You have to have your electronic medical record, and it has to be fully interoperable. Fully interoperability means not only provider talks to one another, but provider and patient talk to one another. My primary care provider in Central Ohio is NCQA PCMH recognized level 2. I spend more time on the computer with him, emailing him and stuff. I do get my annual physical, do that kind of stuff, but you know, if I'm sick, you know, I got that runny nose type of thing, instead of running into his office to get, you know, amoxicillin or something like that, I'm like, hey Randy, you know, I'm feeling bad, here's my symptoms, you know, that type of stuff. He can look at my chart and say, well, you know, I'm gonna call in a script for you over at, you know, Drug Mart or something like that. So you can do more doctoring, right, without actually seeing patients in the office to a certain extent, as long as you've got that electronic connectivity. The other thing is the care coordination piece. Dr. Grundy says, you know, you've got to have that care coordination. So that the other part of it is that in a PCMH, in a patient-centered medical home, you're transforming the way that you actually provide work. I mean, there's a company called TransferMed that actually comes in and helps you retool your whole primary care practice. And you want people practicing at the top of their license. You want doctors doctoring, you want nurses nursing. You don't want a nurse, you know, charting stuff and doing that kind of. And so the other thing is, in some cases with a patient-centered medical home, you have the physician, you might have some physician extenders, you know, physician's assistants, nurse practitioners, then you've got your nurses. And so the physician is actually seeing kind of the worst of the worst, you know, the people that really need to be seen. You've got some other stuff going on. The folks coming in for their annual physicals or coming in with a cold or something like that could be seen by the PA, the nurse practitioner, that type of thing. Then the other stuff is, then the nurses are actually doing some follow-up care for people that they've seen and said, are you taking your meds? Is your diabetes under control? You know, have you been doing your blood glucose screening? Have you been taking your Lipitor for your cholesterol? That's that care coordination piece to make sure that people are exhibiting those health behaviors to reach good outcomes.
So the you know, a key then to this then is the from the primary care provider's perspective, then it becomes the payment reform system.
Payment reform.
Because I was have worked with a large primary care practice at the time, several years ago at the time. The portals to email patients had to interact with patients had come out, and you know the biggest issue I had with the group was that the payment model at that time, or you know a fee-for-service model,
Yep.
does not adequately compensate the physician for the time that they spend.
Right. So Anthem right now, and I don't know if they've implemented, I've worked pretty closely with their government relations person, but in Pennsylvania and Ohio, they're going to start doing enhanced reimbursement for PCMH. On a capitated rate, on a PMPM, I mean, they're saying that they're looking at somewhere between, you know, $8 and $15 additional a month on a PMPM for doing the care coordination piece. They understand that care coordination takes time, takes money, there's an investment in it, but the return on investment, you know, look at it from an insurer standpoint. Do I want to pay an enhanced PMPM for care coordination, or do I want to pay for somebody's foot being amputated for a diabetic, or do I want to pay, how many triple bypasses do I want to pay for? You know, so to a certain extent, even the insurers have started to look at what do we want to pay for? And if they don't want to pay for that kind of stuff, you know, those high cost type of issues, then what are we going to do to push it downstream? And I know, I hope I'm not stepping on too many toes and everything, but when I look at it this way, this is the old, I mean, I spent 15 years in local public health. I was a health commissioner in Clark County, just right down the road and up in Tuscarawas County. So I'm public health. I mean, I believe in public health. When we look at our healthcare system right now, it's an upside down triangle. We spend very little on primary and preventative care. We spend a lot more on secondary. We spend a lot on tertiary care. We need to flip that right back up. We need to be spending a lot on primary and preventative care, very little on secondary, and very little on tertiary care. And that's going to be the challenge of how do you shift payment reform to more primary and preventative care, reaching toward those outcomes, you know. It was funny because, back when I was in public health and we were talking about prevention and stuff, we would say, well, here comes those crazy public health folks talking about prevention and, those types of things. And now here 20 years later, people are wanting to pay for it, so it's like, okay. But that's the challenge moving forward. How do you shift? And anytime there's change, I mean, from a systems approach, just from a systems approach, anytime you change something in a system, it always costs money. I mean, if you change your business model, there's always an initial investment to change that business model, and then as it comes back down to baseline, you'll know if you made a good business decision, if it goes down below the baseline, and actually you're getting a return on investment, right? So now the issue is, where are you going to find the money right now to make that change in investment? And that's where I think, and so you get grants like this to help, do some of that. The CPCI grant is the one I was telling you about that's in Southwest Ohio. This is the one that actually is doing enhanced reimbursement for care coordination. And it actually involves the commercial payers in both Medicaid and southwestern Ohio, so in the Hamilton County area in Kentucky. So there's 75 primary care practices that are involved in that model. What that's going to do is that's going to tell us, what is that return on investment? What are the things we should be looking for as far as the care coordination pieces? How do you do all that? So you've got those practices right now that are in an incubator type of mode, trying to work their way through that. One of the things that Dr. Winslow and I worked on together was the House Bill 198 implementation. In the 123rd General Assembly, House Bill 198 was passed that actually developed a patient-centered medical home education pilot project. We actually found funding for 51 practice sites across the state. And to your point, Mike, none of those 51 practice sites are in Cleveland, Columbus, and Cincinnati. They're in the outlying areas, Southeast Ohio, Northwest Ohio. So we wanted to make sure that we were looking at primary care practices that were out in some of the rural areas. 6 of those practice groups are FQHCs. Does everybody know? Okay, an FQHC is a federally qualified health center. In some cases they're called a community health center. So it's a federal designation. An FQHC has to be in a health professional shortage area, a HPSA. And then what happens is, and don't anybody get mad at me because I'm just the messenger, they're about the only healthcare provider left that gets cost plus reimbursement under Medicaid. So, but they get that cost plus reimbursement because they're working in underserved areas and with populations that normally have a lot of healthcare concern, healthcare problems. So 6 of those are FQHCs. We've involved the 4 medical schools and 5 nursing schools because one of the things that we need to do is on the curriculum reform is looking at how are we training people coming out of medical school right now that they can work in these types of environments. So if you reform the system, right, when you do the payment reform and you reform how you're doing the care coordination piece and everything, but you're not training people to come into it, then the system fails. So one of the things that, and that's going on right now, and it's having some good success. So the whole idea here about what we call blended reimbursement is looking at care coordination, the current fee-for-service model. How do you take fee-for-service care coordination and then work into a pay-for-value type of a model? And so that's kind of the bulwark of what's going on in Ohio right now. Moving from that fee-for-service type of model, because when it's fee-for-service, that's when you're just paying for volume. If I see this person, if I see 29 people a day, I get X number of dollars for that. But what we really want is we want to see care coordination, and we want to pay for that value of care coordination. So actually, if you get on, I pulled this right off of the ODH website. This is something that we did when I was up there that I'm very proud of. We actually developed an interactive map. So if you go on the ODH website and actually click on the patient-centered medical home model, it'll take you to their website, but then you can actually click on this map. There are 8 different drawdown menus that you can go in and you can say, tell me where every hospital is in Ohio, and it'll put a push pin. Tell me where every FQHC is in Ohio, it'll put a push pin. So what we did here is, here's the NCQA PCMH sites, 266. The other PCMH accrediting body, there's only like 5 of those, and then the CMI, CPCI sites, and then HB 198 sites. So once again, you can see where the distribution of some of those HB 198 sites are. They're not in the typical places. They're in Southeast Ohio. They're in Northwest Ohio. We're trying to reach out to those areas where we know that access to care is an issue. We also know that when you get into some of those areas in Ohio, that when somebody does finally end up in your ED and they're coming from those outreach areas, usually they're coming in now with higher acuity. They're coming in with multiple diagnoses because they put off care until it's absolutely necessary. So we're trying to avoid that. Something for you all to think about. This is Dr. Winslow developed the Ohio Patient-Centered Primary Care Collaborative. It's free to join. Get on the ODH website, look at it. But this is a great place to get further information about the whole primary care collaborative efforts in Ohio. Right now there's probably over 300 members involving the insurers, the business community, the education community, and the provider community. They have subcommittees that work on education, that work on access to care, that work on marketing, you know, those types of things. So this is a great place to get information about how about Ohio's reforming some of the care issues.
Well, one of the things that, you know, because we do have a shortage of primary care providers in our county, and so what we're trying to do in terms of the solution is to work through our affiliation with OSU and Mount Carmel. On that previous map, I do know that the OSU primary care sites are all NCQA sites, so it wouldn't surprise me if a lot of those green pens relate to them. So what our intent would be is that is to eventually get to where, I mean, that would be riding on their expertise, and would be to be able to do that within our county.
Yeah.
Because you'll see our county is pretty, that's the one between all the greens and the blues.
Right. And I imagine you probably have some HIPSAs in your county too. If you get on the website and actually click on one of the pins here, it actually pulls up the identifier of what that pin is. So you can actually get on the website, and you don't have to do all the pins. You can pull down whatever you want to pull down. But you know, go ahead, Mike.
Well, then the county over, rocking horses,
FQHC, yeah. Can I brag for a second? I started at the Rocking Horse Center when I was at Clark County Health.
Oh, did you?
Yeah.
Excellent.
Yeah. So one of the things that we saw at the time was there was a lot of folks going into, well, both at that time it was Jerry Mackey at Mercy Hospital, and I can't remember the guy that was at Community Hospital at the time, came to me and said, you know, we're seeing a huge increase in our uncompensated care coming into the ED that is non-emergent type of visits. Is there something that the health department can do? And at that point in time, you know, when I went there as the health commissioner, assessing the health delivery system over there, the health department didn't need to be in clinical type of operations. There was a full functioning, you know, provider network in Clark County where the health department didn't need to be competing with primary care providers and hospitals who were doing that. But what the health department needed to be doing was monitoring the morbidity and mortality of the community and trying to push things toward a different level. So what we did was we sat down and we looked at the census tracts in Springfield where we were seeing all this coming from. And then I went back to the hospitals and I said, here's the deal, I'm going to go apply for this grant, but I need you guys to each put $100,000 a year for 3 years into this pot. We developed the money, and then we started, actually Rocking Horse started with, it was in an abandoned house in Springfield. We started out with an abandoned house that the city had taken over, what, the brownfield site type of environment, and we just completely remodeled it and everything, and then we tore that down and built the first Rocking Horse Center, and then from then on, from what I understand, last time I talked to Dr. Duffy over there, they've done their third expansion on the Rocking Horse. And the way that we got the name for it, when we looked at the census tracts we were serving, when you took a step back after we shaded it in and everything, I said, this looks like a rocking horse, you know, like a kid's rocking horse type of thing. That's where it came from.
Well, we have a free clinic, and the free clinic, the availability or the time to be seen has continued to push out. So we did file to have the county re-looked at for medically underserved tracts, none qualified. So we're currently in the process of seeking an exception. The idea being that would be for Rocking Horse to place a satellite that effectively would replace the free clinic. And I don't know where that would go or where that might go, but that's kind of what we've talked about or have been working on.
We should have a discussion offline because there's ways of, if you want to have that kind of collaboration, that if you could actually place some of those positions from Rocking Horse in a non-HIPSA environment and still have them get the enhanced reimbursement if 25% of the patients coming into that clinic meet the HIPSA eligibility, are underserved. And so I'm more than willing to help you with that. You had questions, Doctor?
I'm not sure if your map reflects this, but we also call this health homes.
Yes.
The health home project that's being developed for Madison County, I think, is actually based out of Clark County. And I don't know if one of those blue push pins in Clark County is that home site.
It could be. Actually, the ones in Clark County might be wrapped around the Rocking Horse Center, and then but once again, if you get on ODH's website and you produce that map and you click on the pin, just put your pointer on the pin, it actually pulls up the name and contact information for each facility.
Okay.
So I'll give you that information. So, and I'll finish up here real quick so we can take other questions. But so the big debate going on right now is the expanding of health coverage, what we call the Medicaid expansion. So remember, in the Affordable Care Act, there's a provision in there that allows states to enhance their Medicaid up to 138% of poverty. So when you say 138% of poverty, these are people that have incomes, what we would call the working poor. So for whatever reason, whether their employer doesn't offer health insurance or their employer does offer health insurance and they just can't afford it, these folks have been historically uninsured. And what we see is that when you start once again looking at the utilization, this is also a group of people that will have high utilization in the ED. So once again, getting them into some level of coverage, some level of care, but then doing some care coordination, once again, training them essentially to be good health consumers can be a benefit to the healthcare delivery system as a whole. In Ohio, you're looking at about 275,000 people that would fall into this category. Now, let me throw some of Steve's useless trivia to you. There's 1.5 million Ohioans that are uninsured right now. What becomes intriguing with that number is 80% of those people are working in jobs. 60% are working in full-time jobs. This is not an issue of affordability. It's not an issue of accessibility. It's an issue of affordability. So If you think about it now, let me go back to when I talked about premium assistance inside the exchange. If you could develop an environment here in Ohio where you had a premium assistance pool made up of dollars, where you could go to employers and say, if you've got employees who can't afford your premium copay, let's help them get on your insurance. We could essentially get rid of 80% of the uninsured in Ohio just by helping them get on their employer-sponsored health care and not even have to worry about government subsidies or government programs. So you could actually bolster the employer-sponsored health insurance market in Ohio, which we believe, well, not we believe, which you can look at studies, is the most cost-effective way of delivering health insurance, is that employer model. So, but that becomes the issue. And the striking number there is that there's a lot of people that are working in jobs that don't have access to health insurance for whatever reason. So, yes, Michael?
When they look at the richness of a plan, do deductibles and co-insurance play into that?
Yes. Yeah, yeah.
Because a huge issue for providers as of recent years is are these high deductible plans with and high co-insurance
right.
plans with employers,
mm-hmm.
and so often we have to get it from the patient to pay.
And that's hard to track down. Yeah, get it. So one of the answers to that, and I've always been intrigued why this hasn't gotten more penetration into the market, is the HSA type of product. We at Strategic Healthcare offer a HSA product to our employees. We're a small company. We've got 25, 26 employees between our Ohio and our DC office.
Well, that's what one of the things that I felt kind of contradicted itself within that act was that, as I understood, the HSA, the limit was dropped down or will be dropped down.
That's on the FSA, the flexible.
So it's not on the.
It's not on the HSA.
Health sector.
But the problem is the HSA, because it's a high deductible plan, is not an acceptable plan in the exchange. So you'll see HSAs offered in the commercial market, but they won't be in exchange because of the high deductible attached to it. One of the things that we see now, obviously we're a healthcare consulting firm, we have healthcare professionals, that type of stuff. But as we've moved to an HSA, we moved to an HSA product in 2007. And the first year we did it, the employees hated me. They thought I was, communist or whatever. And so, but one of the things that we did is we brought, folks in about once a month for the first 6 months, Pizza Friday, and then we brought the broker in, we brought people in to say, this is how you use your HSA product. A year later, the staff was like, don't get rid of my HSA, I love it. Two things. Number one, what we did was, at that point in time, we were probably paying, for an Anthem PPO product, we were paying a little over $12,000 a year for a family PPO product. When we went to the HSA, that same PPO product, no change in benefit design, but just going to a higher deductible, went from $12,300 to $6,500. So it was about a 40% change in premium. We took some of that savings and actually funded the HSA account for the employee, and then we funded half of their HSA account and they could fund the other half. So we had a $4,000 deductible. We put $2,000 in their HSA account, encouraged them to put the other $2,000 in, which is a tax shelter to them because that's $2,000 they don't get taxed on their income. But one of the things we saw a year later was, you heard employees coming back and saying, when we were doing kind of some of the follow-up, saying, well, yeah, I go into the pharmacy to get my medication, and the pharmacist says, well, and we go in and we ask for the generic, and the pharmacist says, well, why do you want the generic? You have insurance. And they say, well, this is coming out of my HSA account, so I want the generic. You have folks going into the doctor and saying, why are we doing these tests? And so you get people becoming better consumers of healthcare, which helps to control some of those costs.
Well,
so
I don't know if this would be an accurate statement or not, but when I have talked with colleagues of mine that work in a professional services industry, say accounting firms or something like that, the HSA model seems to work wonderfully. But then when I look at it with, you know, when you get into a workforce and, you know, you've got a large percent of your workforce making 12 to 15 bucks an hour, it doesn't seem to go the same.
Yeah,
and the, you know, and actually, the health condition between the two are a lot different as well, two populations.
So here's some things, you know, well, to wrap up, here's some things that, you know, that we're, to think about, we're kind of seeing. You know, eventually all healthcare is going to be regional in approach, you know, and I always tell folks, you look at the children's hospital system here in Ohio. You have 6 children's hospitals. They all work within a region. Very little of those regions overlap with one another. They've kind of figured it out and said, you know, here's our catchment area, there's your catchment area. But within their regions, they have a system of providers, a network of providers that they work with. We potentially see, you know, I can't tell you 7 to 10 years from now, that even on the acute care side, that there could end up being 6 to 8 regional systems in Ohio. You know, just because of what we're seeing, all this, the care coordination pieces, the electronic connectivity, all those types of things, that you could actually see more of a regional approach of healthcare happening. On the insurance side, one of the things that I won't doubt that you'll see happening, and I, you know, tell folks, I remember as a kid growing up, my mom and dad had Blue Cross Blue Shield. I mean, we had hospitalization. Remember hospitalization? You didn't have coverage outside of the hospital. If you went to the hospital, you had really good healthcare coverage. And then eventually we started expanding that, HMO, PPO, first dollar coverage now, you know, pharmacy benefit, vision, dental, all this kind of stuff, and that's what's made hospital level. Watch what's going to happen now, because you're going to see some of the health insurers going back to employers and saying, I can offer you a catastrophic health care plan for about $1,500 per employee per year. It'll give you great coverage once you go in the hospital. Outside of the hospital, you know, you're kind of on your own. So the question becomes, how do you take that philosophy of the HSA account and even attach it to like maybe a catastrophic plan so that people can invest dollars in their HSA account and then go and buy, you know, care when they need it. So, I mean, and I'm not going to say that that's going to be the end all, but for employers that want to continue offering health insurance, I mean, don't forget this, that, you know, over the last 10 years in Ohio, employer premiums have more than doubled. But their revenue hasn't doubled, you know. And so for them to remain competitive in their markets, and as our markets become more global, to remain competitive as a manufacturer, as somebody in the high-tech field, I mean, we're seeing more and more small businesses pop up in Ohio, wrapped around high technology, wrapped around biomedical technology. And so those small employers, if they want to offer health insurance to their people, they've got to figure out, how am I going to offer health insurance and yet remain competitive in my markets? Yes,
Are those catastrophic plans, though, qualified plans?
Nope.
So you offer that kind of a plan, plus you have to pay the tax penalty?
Yeah, so
it's not a qualified plan.
And that's one of the things in what I just heard the other day. I get a couple of different newsletters from, you know, Politico and those types of things, where there seems to be some interest by members of Congress that next year to reopen up the ACA and do some tweaks to it. And I can't tell you what this would be. One of the tweaks is to make products like that more accessible and fit within the whole idea. I would say from the politics side of it, the slippery slope for the Democrats is that if they open up the ACA in the House, which is controlled by the Republicans, they would probably do everything they could to destroy the ACA, and so it doesn't happen. I mean, there's been 37 bills introduced in this Congress by the House to repeal the Affordable Care Act. None of them pass. Or they pass the House, but they never get to the Senate. So there's some of that dynamic. But I think that my point being is that we're going to have to get a lot more creative about, on the insurance side and, you know, even on the provider side, about how we do some of this stuff. So speaking of which, the biennium budget update. So this has, so House Bill 59, which is our 2-year budget, you know, Ohio works off of a 2-year budget, was introduced in February. 3 major policy initiatives that were being explored were Medicaid expansion, education reform, and tax reform. Those are the 3 big things that the governor was trying to approach. Just so that you know, I mean, when the budget bill was introduced, it's 4,206 pages long. So it's a relatively large document. And if you think that healthcare is kind of crazy and stuff, out of that 4,206 page document, over 1,000 pages of it is education and the education funding formula. So it tells you how crazy that whole system is. So it's been voted out of the House and voted out of the Senate. Actually, it was voted out of the Senate yesterday by party line vote, 23-10. It will go to conference committee beginning probably next week, next Monday, Tuesday, and they'll be beginning working deliberations on differences between the House and the Senate provisions. The governor needs to sign the bill by June 30th because it becomes effective on July 1. And one of the things we've heard just as of yesterday was you know, when the governor introduced the bill, Medicaid expansion was in the bill. The House took Medicaid expansion out of the bill. Representative Barbara Sears out of Sylvania up in Toledo put some language in on the House floor as they were voting it out, kind of like placeholder language. She has since then introduced a standalone bill. The Senate actually stripped her provision out of the budget bill, that placeholder language, yesterday. But the word we heard late yesterday, the reason why they did that is because there is a chance that in conference committee they will reinsert some language regarding Medicaid expansion so it can go back to the governor on June 30th with Medicaid expansion in it. So we're going to pay attention to that and see what that looks like. So with that, I'll answer any questions. I don't know if this was